should now see my
Yes.
slides. And all right, so we are going to move on. We've already started talking about dose. Thank you for those questions, Tanya, and for the others that have asked the question. So now we're going to kind of shift and talk a little bit about how dose affects the image quality, the other side of the equation. So when we talk about radiation dose, obviously remember, this is the big picture here. We're talking about diagnostic reference levels. And how do we use diagnostic reference levels to optimize dose? So we send off the data, all that data, Dr. Panru Tai and her team, they've established Thai national DRLs. And now those numbers are going to come back to the hospital. And those values are we're going to use in our optimization team to try to decide what we should do to make an informed decision on what we do. Do we reduce our dose? Maybe in some cases we increase our dose because then they were too low. And so the DRLs help us standardize what is a quote unquote acceptable level of radiation. And so if we establish the national DRL for a routine brain, let's just say it's 35, let's say it's 40 CTDI. The volume CTDI is 40 milligrays. I just picked that number. I don't exactly remember what it was when we looked at it 2 weeks ago. But let's just assume it's 40. And you look at your data at your hospital, and if you're above or below that, you need to now make a decision on what we do with that optimization. The fact that the 40 value was set, that just says that 75% of all of the hospitals in that provided data to in this calculation, so 75% of the hospitals in Thailand are imaging at that value or below. And so if you're above that value, you have to ask yourself, is there a reason why I am above that value? If there is a reason, then you're okay. But if there is not a good reason, a good justification, then we know we can lower it. And that becomes this idea of moving all of the Thai data or imaging towards an acceptably lower level. And this will help us understand kind of how we do things and we use our imaging on a day-to-day basis. But the question I had from the very beginning, we talked about risk. At the first week, we talked about radiation dose risk. And in Thailand, for example, your natural background radiation is very, very low. And therefore, the amount of radiation your population, the type of radiation your population is most exposed to is actually from medical imaging. So what is the total dose burden from imaging to the Thai population? And so that's something that I would challenge you, as now you've established DRLs and you're starting to roll out this new technology, the dose monitoring software, you're going to get to the point where you can collect a lot of data very quickly. And I want to show you some examples of how we do it here, of course, in the US. Every country does it a little differently. But what we've been doing for the last really couple decades is we have been doing surveys where we look at the total population survey for medical imaging. And there have been 2 publications of this data. So the first was in 2006. So basically they looked at data from late 1990s up to, I think, 2004, 2005. And that's what the data is in the left side. And then from 2006 to about 2014, they collected that data and then they published it in 2016. And that's what the data is here. And so you can see in up to 2006, we acquired in the US 377 million exams, medical imaging exams. And it broke down by mostly 281 were planar radiography and fluoroscopy. CT, which of course is what we're talking about here, accounted for 62 million. Now fast forward 1 decade, and here you can see CT usage is up 74 million, up from 62. The total amount of imaging actually decreased by 7 million. So CT went up, total went down. So therefore, other areas like radiography, fluoroscopy, nuclear medicine, other areas have decreased. This is helpful because not only does it tell us what we're imaging, or excuse me, what type of modality we're using to image mostly. So when it comes to doing optimization of radiation dose and image quality, you get an idea of where you should focus your efforts. Obviously, CT is increasing, and maybe, for example, nuclear medicine is decreasing. But you can now look at the total dose burden to the population. So on the left-hand side, the radiation dose burden for kids being imaged, 84% comes from CT. And so if I want to make a positive change for the amount of radiation we use when we image kids, changing something in fluoroscopy or nuclear medicine doesn't make as big a difference. But if I make a small change, albeit small in CT, I'm going to affect 84% of my pediatric population. Now compare that to the adult plus pediatric population. CT is actually only a smaller chunk of that. We still do a whole lot of just planar radiography and fluoroscopy in the adult world. Even though we do a lot, don't get me wrong, we do a lot of x-rays and fluoroscopy in kids, but they just account for a very, very small amount of the radiation dose. Whoops. All right, so when you look at the dose here, oh, I'm sorry, I actually misspoke. I said dose burden. My sincere apologies. This isn't dose burden, this is usage. In kids, no, I'm sorry. I'm all confused. My apologies. What I said was correct. This is dose burden. 84% of the radiation dose in kids comes from CT. When you look at kind of the adults, so this is adults total population dose. So this is kids and adults. When you look a decade ago, we were about 3 millisieverts, and 50% of that came from CT. If you go forward to 2016, the dose burden has actually decreased. We've gone from almost 3 to just a little over 2. And even in that time, the usage of CT has gone up. And a big part of that is what we're going to talk about today, of all of the positive optimization that we have done, like we've talked about already in the last hour, and we will now talk about now. All of those efforts that have been put into place for about a decade have paid a huge dividend, have reduced the overall population dose, even though we're using imaging more. So one would argue we're imaging safer now. Here's just a breakdown of the CT of once again here in the US, but brain imaging only accounts for a little less than 20% compared to, abdomen and pelvis, which is 26%, chest is roughly 16%, head and neck is about 10%. And when you look at the overall dose per exam, brain is right here, a little less than 6%. It's this blue chunk right here. So about 20% of all CTs in our total population are brains, but they only account for less than 6% of the dose. And part of that is because the anatomy that we have up here is not as radiosensitive. The brain, our glands, and our eye lenses are probably the most radiosensitive. But besides that, it's just muscle and a little bit of fat, and there's not a lot going on for us. But most of the radiosensitive anatomy is down here, especially in the chest and the thorax, but definitely in the chest, abdomen, pelvis area. And so that's why when you look at the overall dose burden, 26% of the scans in CT are for the abdomen, pelvis, but the dose burden here is 38%. In chest, we do about 16%, and here it's 18% dose burden. So when we look at the chest, abdomen, pelvis, that is a big chunk of the dose pie over here, which we'll talk about next week. So it's important to know kind of that proportion. We do a lot of brain imaging, but it doesn't as much affect the overall total dose. So brain plus head and neck, 28% of all total imaging, but only accounts for less than 10% of the dose population. So it's important that we optimize brain imaging because the radiologists need to see what they need to see to make their diagnoses. But do we need to worry about it as much for risk? No, we could probably focus a little bit more on the abdomen pelvis if we're looking at it purely from a dose perspective. All right. That's basically what I just said. So I mentioned in the last decade, at least here in the US, well, let me step back. So why did I go through this process? This is US data. I'm talking to my friends here and the Indochina Peninsula. And you guys, I strongly recommend that this is a direction that Thailand and everyone listening goes. As you now have established diagnostic reference levels, the next big step is to understand the overall burden. Well, burden is probably the wrong word. Usage or utilization. So, how much is going to CT versus planar radiography and mammography and fluoroscopy? That's one type of study. And then the next study is the overall dosing that goes into that. And so it's wonderful that you guys are getting the new technology. You're going to get radiometrics. It's going to be widely distributed throughout Thailand. And as you then start collecting that data on the national level, I strongly recommend, and I hope one day we'll get to see all those types of pie charts, because it then helps you understand where best to focus your optimization efforts to make the biggest, as we say, bang for your buck. You want to make the biggest change that can cause the greatest good to happen for your population. All right, so, excuse me. We talked about how image quality, we talked about how when new technology comes out, we should constantly be reassessing for image correcting for and using that new technology for improving image quality and potentially reducing radiation dose where impossible. And I demonstrated that over the last 10 years, we in the US have been we've been acquiring more CT scans in our medical population than we did a decade before. And we've been doing it at lower doses. And it's all because of, and this is, I think it all just encapsulates it in this one slide here. You see on the left side here, the first clinical CT scanner developed by Dr. Hounsfield. And it only scanned the brain. So it's actually quite interesting that we're talking about the brain today as the first modality of choice. And it's not even the whole head. We couldn't do face imaging. They couldn't do facial imaging. Definitely couldn't do neck. It was quite literally just the top of the head. It was the cranium. This is the first clinical scan of a human. And you can see that it was, is for as low a quality as it was, it still got the job done. You could still see that there was something there. And so you could diagnose the disease in it. Ironically, it took 4 minutes to acquire the scan, and it took 24 hours to reconstruct it. And there was no such thing as CTDI. There was really no idea of how to determine how much radiation they used. Fast forward to this year. This is just an image I took off of PACS, and I've already shown you several images from this patient in my previous talk. This was acquired in 0.275 seconds. The reconstruction time took less than 30 seconds, and it had a volume CTDI of 25 milligray. So we had an idea to understand about how much dose it got. The quality, obviously, is just, there's no comparison. It's infinitely better. And so the concept here is technology will drive better image quality improvements and lower doses. And so we constantly need to take that image quality, that new technology that comes out, and constantly invest in it. And so if you're using a CT scanner, which I don't know if you can, but if you're using a CT scanner that's 15, 20 years old, you're not doing a service to your patients. You really do need to do your best to try to keep the newer technology. Now, I know there's a lot of reasons why not every hospital can afford the latest and greatest CT scanner, or they just don't have the patient population that needs a lot of scanning. So there are a lot of other factors beyond just getting the best image quality. But as an optimization team, radiologists, physicists, technologists, and our IT friends, we have the opportunity to hopefully talk to and help influence the hospital to make the right decision when it comes to buying new scanners with the latest and greatest and best technology. All right, so we're going to talk a little about applying diagnostic reference levels to patient monitoring today. So just a quick review. I know I've already talked about this, but I'm going to talk about it every week as we look at the various different modalities, just as a refresher and as a reminder. So what are not DRLs? How should we not use it? Well, they're not to be applied to individual patients. So you scan a patient, it has a CTDI vol of 25 milligray. You can't necessarily compare that value to the DRL. And there's a reason for that. We've talked about it, but you're not supposed to just make that direct comparison. They're not to be used as a limit for the amount of radiation we use to acquire patient examinations. So what I'm saying is you don't get the DRL and say no one can ever go beyond that. That is not actually what a DRL means or is to be used for. It's not to be used for regulatory purposes where the government comes in and says nothing over this level. And it should not be used to penalize a hospital. So if a radiation dose is above the DRL, there may be a reason for that. But it should never be punitive where if a hospital is imaging over that value, that there is some kind of penalty that is applied. How should we use it? Well, it's an optimization tool, and I'm going to give you examples of that today. It defines a level or helps us define a level. Remember, I say it's like a line in the sand. It's a point where we say, okay, if we're over that line, we should look at things. We should investigate. It's simply meant to be a test, and it's helping us find unusually high values or unusually low values. And we already know, but what is a DRL? It is the 75th percentile or the third quartile of nationally acquired data. It's not only nationally acquired, but it's vetted. We talked quite a bit about getting rid of the outliers on the low and the high side. And we talked about the proper ways to make those calculations. But once you get good data you've looked at the distribution and everything looks good, the value at the 75th percentile is the national DRL, can be applied as the national DRL. And then the second value is at the median, the 50th percentile. And that is what we consider the achievable dose. If everyone is imaging at or below, not everyone, but if the majority of people are imaging at or below 75th percentile, 75% of all the hospitals, that's a good thing. But there are still 50% of the hospitals that are imaging at this value, the median. And so the goal would be that if you are at the 75th percentile, maybe you can lower yourself down to the 50th percentile. And that's why we call it the achievable value. And I'm going to give another example of that today. And what are the values that we should use to calculate or to track for DRLs? We talked quite a bit about the volume CTDI and the DLP, and that is what you guys have done. And Ty, you have national DRL values established around these two. There are also opportunities to use SSDE, probably not now, but definitely going forward, SSDE I think is going to be a very important metric. And the big thing that will change is currently on all CT scanners, it is required to display the volume CTDI and the DLP. The IEC, which is an international body that helps regulate and all of the various vendors of the CT scanners, they're the ones that come up with the standards that each of the vendors must meet so they can build and sell their scanners. They've just approved and are now requiring that SSDE will be displayed on all CT scanners. So now you will see CTDI, DLP, and eventually with the newer CT scanners in the next probably year or two, you'll start to see SSDE. So going forward, there will be a need for a national DRL, probably with SSD. But we can argue and we can, well, not argue, but we can talk about that at a different time. Effective dose is not appropriate and organ dose is not appropriate, as we've discussed. It is important to point out that the IAEA and some international journals have started calling the volume CTDI the volumetric error Kerma index, or CVOL. And they've started calling the dose length product, they're now calling it the error Kerma length product, or P sub KL. It's just important to point that out. What you choose to use, the definition, the title, the wording, that's really on you. Obviously, all the vendors still use volume CTDI and DLP. We here in the US still use these terms also, and Europe also uses them. But like I mentioned, the IAE has started using these terms, and there's a reason for that. That's beyond the scope of this conversation. We can talk about it another time if you do want to know that. I can say, as someone that sits on the IAC for CT, on the CT committee, they have not moved towards adopting these values. So I don't think you will see these values anytime soon displayed on your CT scanner. So staying with or continually using volume CTDI and DLP is a very safe and a perfectly appropriate thing to do. All right, so which predictor should we use? Obviously the volume CTDI. Why is it? It's great for optimizing scanner protocols. And it's good for setting alert levels when we're trying to track changes when we're imaging patient to patient. DLP is great for predicting the total energy imparted to the body. And that's obvious because, as we talked about, CTDI is simply the average value at the center of the scan field. So if this is my scan field, CTDI is the average value right in the middle of that. Whereas dose length product will tell you the overall estimate of dose imparted to that entire volume. And once again, it's also good for setting alerts to capture not only the overall output, MA and KV, which is what we use to calculate for CTDI, but it tells you the length. And so if you have one brain protocol and you're looking at it and you have a nice average distribution of dose length products, and one patient comes in and the value is so much higher than that, well, most likely the MA is fine and the KV is fine, but what's different? The length. And so dose length products are really good for helping us understand if we're doing all of the right things. We're not only setting the right MA, we're setting the right KV, but we're also making sure we're setting the right scan field of view. All right, and then SSDE, as we've talked about, the size-specific dose estimate is good because it helps us convert, or it helps us better use volume CTDI to predict actual dose burden to the patient. CTDI vol, that is a value that is, and this is why the IAEA has started to adapt it, started calling it the error Kerma, or the volumetric error Kerma index, because the volume CTDI is a value that we calculate for the center of the scanner in air. It has nothing to do with humans. You could go scan a block of wood and it would have the same volume CTDI as a human would. But when you start doing SSDE, it starts to take into account the attenuation differences of size differences of the patient. And so it gives us a better estimate for what the actual patient would get if we calculate patient dose. All right, effective dose, we already know this, we've talked about it, but it's not patient specific and it should not be used for alert levels. It is, though, really good if your total optimization program is looking at making, optimizing fluoroscopy, radiography, CT, nuclear medicine. But if you calculate the patient population exposures in each of these modalities, each of those modalities have their own dose metrics. Error Kerma, CAP, volume CTDI, DLP, millicuries per kilogram, all of these metrics, they're so much different. But if you can calculate them all If you can convert them all to effective dose, then you actually have a way to compare dose output for each modality. So, not good for alert levels, but great if you're just trying to do overall comparisons. And then organ dose is definitely not great for dose reference, diagnostic reference levels, or setting, um, doing that kind of stuff. Frankly, we can't really even really do organ dose calculations yet real well, but they are the future. And everyone is working towards this idea of being able to do auto organ contouring on every CT scan so that we can do dose prediction per organ. And that, once again, is its own talk, and I won't get into this. But we always talk about what is the risk to the patient when it comes to CT scanning. We don't know what the risk is because we don't actually have patient data. We have machine output data, volume CTDI, DLP. We have better approximations such as SSDE. But until we can actually start calculating true organ dose for each patient on each scan, we really will never get to an idea of what is true risk. And so organ dose calculations are great for the future. They're a research tool at this point, and they will be a wonderful way for us to understand true population dosimetry, but definitely not a good tool for diagnostic reference levels. So as I mentioned, what we've done now, you have done now in Thailand, is you've created these national DRLs. And so at the local level, you, the hospital, will take your values, you'll calculate the median dose. This is why it's not a patient-specific value, but you'll take the median, say let's look at 100, 200, 2,000 brain scans, face scans, neck scans, whatever it is you're trying to optimize. And then you get the median of that value, and then you compare that to the national DRL. And this will help us know what we're going to optimize and where, we should optimize. And then just as a reminder, I showed this slide last week, or 2 weeks ago, I should say. You need to know that the value you're using to compare at the hospital to your national DRLs is a good value. It's accurate. And so you need to be constantly checking, for example, the volume CTDI to make sure it is accurate. And the only way to do that is to test it with a standard. And so you can use a CTDI phantom with an ion chamber. You place it inside your CT scanner, and your physicists there are going to verify that the value listed on the CT scanner and the value that is recorded with every patient examination is accurate. And so you want to have faith in the numbers that you have. Good data will give you good results. If all of your CTDI numbers are completely wrong, how do you optimize? And so checking those periodically, at least once a year, is a wonderful way to make sure you know or your team knows what to do. So we talked about this already, but when we talk about radiation dose optimization, it is also a team effort. So going back to this chart, this interconnected web chart, we were a moment ago talking image quality, about an hour ago. And now let's focus on the dose side. When you can see here, this dose side, this yellow box, it actually points to only points to a very few amount of parameters to affect. And so there are small features for us to optimize. That's actually a good thing. It makes our task not as complicated. But whoops. Sorry, pushed the wrong one. It's important to notice that not all the features directly affect image quality. And so if you look at it, this radiation dose value obviously is affected by changing any one of these things like tube current, tube voltage, rotation time, pitch. Well, we'll explain that in a minute, but any one of these factors right here will affect the output, radiation output. But radiation dose right here, as you can see, as I draw this line back, it goes back to one of the other higher level optimizations that we're trying to take into account, risk. And so when we deal with risk, we also have to take into account some of the other factors like patient age, sex, etc. And so radiation dose initially, I mean, is directly connected to these things, and obviously the patient parameters. You can see these lines right here as they go up to height, weight. Obviously, the patient's size will affect the radiation dose. Um, and then the other thing, sorry, I keep pushing the button, and I'm trying to use my mouse as a pointer. There we go. Radiation dose, you can see, has as it points to all of these parameters here, as we talked about last time, these parameters also point to image quality. So radiation dose, as we change the radiation dose knob, it's going to have effect of risk, as I was just talking about a minute ago, and image quality. All right. It should be pointed out, though, it's not really appropriate for this talk, but this idea of appropriateness, I think, is probably one of the best ways to reduce patient radiation risk. Is the imaging appropriate? Is the task necessary? And if it is, then obviously the next step is to make sure we got the right image quality and the right dose. But if it's not appropriate, then removing the need to make those images or to scan those patients really reduces the amount of radiation dose we give to our patients, because we're taking that away, and it obviously completely reduces the risk to that patient. So not part of today's discussion, but I think it's always very important for us to constantly look at the appropriateness of all of our protocols and the reasoning for why they're ordered. And once we know and have a strong, and we believe that they are appropriate as they've been ordered, then the next goal is to maximize the benefit to risk ratio. All right, so the first steps in dose optimization and establishing what I would say, quote unquote, is appropriateness is setting specific guidelines for ordering CT. And so I'm just going to give you this example. This is something that we do here in the US. I imagine you guys do this. You probably have something equivalent to this in Thailand. But head CTs are one of the most commonly ordered CT exams for the kids. I showed you that in those pie charts. And so there is an organization here in the US called the Pediatric Emergency Care Applied Research Network, or PECARN for short. And what they did is they went in and they looked at when is it appropriate to use a CT to scan for traumatic brain injury. And they basically said that if they meet very specific criterion, then yes, scan. But if they do not meet those specific criteria, that there really is never a reason why we should CT scan. And then in many cases, even if they meet some of the criteria, but not all of them, then we can still observe the patient, and that might be sufficient instead of needing to CT scan them. So they came up with, the PCARN came up with this flow chart. And so I'm just going to walk you through an example of this, as you can see how they established this idea of appropriateness for using CT. And it's all based off of the Glasgow Coma Scale, or the GCS. And so if you have a GCS score of somewhere between 14 and 15, and I should also mention it's been divided into, if a patient's less than 2 years, you use this flow chart, and if they're 2 years or older, you use this flow chart. So I'll just use the example of a patient that presents 1 year old, and they have a GCS, let's say it's 14. And if they have other signs of, say, altered mental status or palpable skull fracture, then yes, it's probably okay for them to get a CT. But when you consider the total population for folks with GCS of 14, altered mental state, and palpable skull fracture, that only really accounts for about 14% of the total population. And when you consider the clinically important traumatic brain injury, or the CITBI, that really only accounts for about 4%. Now, if the patient has um, it doesn't have this set of criteria, um, then you need to ask the next question. Well, is there an occipital, parietal, or scalp? So if there's a scalp injury, a hematoma, if there's a visual effect beyond just maybe palpable skull fracture, if there's a history of loss of conscience or severe mechanisms of injury, maybe they're just not acting normal, then if that's the case, then beyond these original criteria, then yes, we should order a CT. And in this case, now more of the population falls under this umbrella, about 33%. But still the potential for risk is fairly low. And so in this case, really they give some more criteria saying you could still probably observe these patients unless maybe, for example, they're less than 3 months, or the physician isn't as comfortable, and so they just want the CT scan to rule out. But if they don't have these initial criteria of GCS score of 14, etc., and they don't really have scalp problems damage, or they haven't had a loss of conscience, then the answer is no, a CT is not recommended. And when you look at the total population, generally speaking, 53% of kids that present where they are being observed for TBI, for traumatic brain injury, 53% of them don't need a CT scan. And it's just because if you look at all the various different criteria, they don't quite meet all of these. And so if they just simply observe the patient, and as long as the patient, there's no altered state or nothing happens, then the patient can eventually go home, or, go on to other different clinical indicators. And so setting up an idea of how to when to CT scan is probably, like, as I've already said this once, I'll say it again, is probably one of the best ways to reduce, quote unquote, reduce radiation dose to kids, but even adults. And so setting up that level, and that's probably that's maybe higher than the dose optimization team. That might be something where you need to really bring in the leader the leadership of radiology, and maybe other groups like pediatrics or surgery or a few other, the emergency room. They may be able to come together and help decide when we order and when we don't order. So, but having those discussions is a very important one. All right, the next step to considering for dose optimization is clinical indication. So we can actually optimize the dose based on what we're looking for. And so if we are looking at an inherently high contrast indication, so if we're looking at hydrocephalus, or shunt drain placement, these are clinical indications that most likely do not require a lot of radiation, because the image itself presents with an inherently large amount of radiation. So if there's a lot of noise in the image, you can still see maybe the overall extent of the hydrocephalus, and you can definitely see where the shunt is located and is it in the right location. And so you might not necessarily need a lot of radiation. Whereas if you're looking for subtle bleeds, or low low contrast tumor or something, then yeah, noise could obscure that, and so you would need to make obviously an appropriate adjustment to make sure the protocol is set up to acquire a little higher radiation dose in that regard. All right, so transitioning now. So we've talked appropriateness, we've talked about setting up protocols based on clinical indicators. Now let's get into kind of the when how do we set up the protocols for proper dose optimization. So Tanya mentioned this, and I'm just going to demonstrate through this with some data here. Our heads grow logarithmically. They grow logarithmically laterally and also craniocaudal. And so little kids will see a large amount of change in their overall head diameter in a very short amount of time of their lifespan. And then as time goes on, basically from 2 to 5 years old, we see very little change in our overall head size. And so that's actually a good thing, because we can use this knowledge here to establish how many protocols potentially we need to establish. Because we definitely need to be able to account for imaging really small heads versus really big heads so the CT scanner can get the right dose. But the other thing is the overall density. And so here I just went through and placed a bunch of little ROIs and all this, which is not really easy because there's not a lot of anatomy to measure the CT number of the of the calvarium or the skull. But what you see is also the density of the bone. The bone ossification changes logarithmically over time. And so little kids have fairly they have not as dense bone and not as ossified, and so we don't necessarily need as much radiation to image a little kid as we do older kids and adults, of course. So the first step here is if the head is changing logarithmically in size, how many protocols should we use? I give you an example of how we do it here. We're a pediatric center, of course, but we chose to make a protocol that covers just 0 to 6 months. And why is that? But you can see the most change in the head diameter is in those first 6 months. And then the next one would be 7 to 24 months. And forgive me, I didn't put a line here for 0 to 6 months because there's really no way to put a line right there. So the next line here, what I'm showing you is basically up to 1 year to 2 years, 7 to 20. Yeah. Whoops, my lines. Okay, I'm sorry, my lines are off here. That was 0 to 6 months, and then 7 months to 24 months was this line right here, which as you can see is the next biggest change in the anatomy. And then this 1 to 2, that's a mistake. And then the next one is 2 to 5, through 5 years, so up to 6 years, and then everything beyond that. So the most change happens at that really young age, and then there's the next one down here. But as we get a little older, basically after 2 years old, there's not a lot of change in our overall diameter of our head. And then, as I mentioned, skull density matters, all matures logarithmically too. And so, as we set the proper techniques, one of the most important ones in the head is setting the right tube potential, or the KV. And that's because the KV helps drive the penetration. If we have an energetic photon, it's going to be able to get through our thicker skulls, our more dense skulls. And so generally after the age 2, we're still typically imaging at about 120 kV. Now every vendor is going to have their own settings. Some may be able to, some may allow you to set something besides 120, but generally speaking, after 2 years old, you're imaging at 120 kV. Now, the caveat to that is you really get better gray-white differentiation, better contrast at 100 or less kV. The higher the kV, the less or the lower the contrast, inherent contrast in the image. And so in a perfect world, we'd really like to image using 100 kV. But that's why we set several protocols, 5 of them up, so that we can actually image several of them at 100 kV for the little kids, and then a couple and the rest at 120. We talked quite a bit about this, so I won't belabor this point, but fast imaging is really good, especially helps to minimize motion artifacts. And so how do we do that? Well, you have those high pitch, fast, so the high pitch, large beam width, fast acquisitions if you're doing helical. And I give you an example. If you have a Siemens scanner, they have what's called a flash mode. Or you use those wide volumetric coverages, such as GE and Canon. And where I've indicated almost all patients, their overall the length of the scan, say craniocaudal, almost all patients would fit within a single rotation axial if you have the ability to image out to 16 centimeters. All right. So the other thing to consider when we're optimizing dose is we talked about how the anatomy in the head is not as sensitive compared to, say, lung, breast, stomach, colon, everything from the neck down. But the eye lens is actually, and so we will have to be careful. Too much exposure to the eyes can induce cataracts. And so that is the principal reason why we angle our CT scanner to try to image we're imaging the cerebrum, but we're doing our best to not directly image over the eye. Now, there's two ways to do that. Obviously, there's the physically angling the CT scanner. Not all CT scanners can physically be tilted. There are a couple of out there, specifically the GE scanner, the Revolution, the Apex. They're bolted to the ground. They don't tilt. And so, and all vendors do this now, but there has been a development of using what's called organ dose modulation. So just like tube current modulation, as it rotates around the body, it can change MA for thin areas of the body and thicker areas. But organ dose modulation gives us the opportunity, as the X-ray beam sweeps anterior over the body, there will be a point where it's covering or it's sweeping over the eyes, and it will automatically reduce the MA over this arc compared to all of the rest of the sweep. And it can also be applied down in the body. And of course, that arc will be a lot greater because in this case, now we're really trying to reduce the dose, for example, to breast tissue. But up in the head, our eyes, and down in the neck, our thyroid, those are kind of the more sensitive ones. So if we turn on organ dose modulation, here you can see this is a piece of film that I cut and I sandwiched between two CTDI phantoms. And then I imaged it with organ dose modulation off. And the dose is, for all intents and purposes, homogeneous in the volume. You're going to have a little less radiation at the dead center, and that's because of attenuation. But for all intents and purposes, the yellow is pretty much the same around the edge, and it's just a little lower in the middle. Now, when I turn organ dose modulation on, I've actually reduced the overall radiation dose to this anterior sweep by about 25 to 30%. And then the radiation dose is going to be obviously higher around it compared to the center or to the anterior sweep. There is one vendor out there. Almost all vendors, when it passes anterior, it reduces the MA, but then as it keeps going, it goes back to normal. There's one vendor that reduces the MA here, and then it turns the MA higher over here. So the total MA is the same in the center, but that means that some of it is a little higher down here. Others, like I said, they just reduce the MA up here, and so the total value is actually a little lower. Now, the question you would ask is, if it's going to reduce the MA as it sweeps over the anterior aspect of the body, is it going to change the image quality? Are the more anterior portions of our anatomy going to be noisier? Because obviously you have less MA. So the answer is no. This was a cadaver that we scanned, and we asked that question: does tube current modulation plus organ dose modulation reduce the image quality compared to here? Now, one may argue that it is slightly more noisy, for example, here in the orbit. And the answer is, when you draw the ROI, the Hounsfield unit, the noise is 4 Hounsfield units here, and over here it's 4 Hounsfield units. So metric wise, mathematically wise, it isn't. Visually, you could probably say it's just a little bit, but it's been in our practice of using this, the radiologists have never ever complained, and they've never ever said anything negative about it. And so I think the change is depending on maybe your sensitivity as a radiologist. It's hard to say that you'd really see a difference, but you may. All right, so those are kind of a couple of the different aspects in which you can, different ways to apply dose optimization when we're talking about imaging in the brain. So I'm going to give 2 examples of now how we apply the DRLs to our own personal hospital data and how we can set alert levels so that you can, as an optimization team, know where to operate and how to make the biggest impact. So I'm going to give two examples. The first example, of course, was going to be my data from Cincinnati Children's. And what you're going to see here is for over a couple of years, over 2 years, I looked at about 4,000 scans, and I looked at brain CTs with and without, so two-phase CTs. As I mentioned, we actually have 5 now, but previously we only had 4. 0 to 6, 24. Yeah, there's one missing right here. Yep, there's one missing right here. 7 to 24. So there should be 5, but yeah. So there should be 5. Back in the day, we only had 4. So I guess I'll just say that much. And that's why you see 4 different colors. And the dosing, you can see, is slightly different. So our little guys, they just didn't need as much radiation. Like I said, their skulls aren't as dense. So we can get away with using 100 kV, maybe a little lower MA, compared to our over 13-year-olds or our quote unquote adults, dope protocol that does require a little bit more radiation, definitely at a higher kV to penetrate the skull. So the first thing you can do when you look at this data, and I should also point out, we used fixed MA, which is obviously apparent to you because the data is a flat line. It is horizontal. If you use tube current modulation, you would see a lot more of a scatter. But we just personally use fixed MA for a variety of different reasons. So the first thing I can do is I go to our national dose reference level, and I can look at all our data compared to the national DRL. So here in the US, the national DRL volume CTDI is 60 milligray. And the achievable dose is 50 milligray right here. Now, it's worth pointing out that at least here in the US, those values are not pediatric specific. They're all adult specific. And we here at Cincinnati Children's, we looked at about 500,000 data points across the nation. So not just our data here at Cincinnati Children's, but at all the hospitals that image kids. They're either children's hospitals, which are these blue and purple ones, or quote adult hospitals that image kids, which are the red and orange ones up here. And so what we did now is looking at just kind of the average. Remember, the DRL is the 75th percentile, so it's the top of all the boxes. So if you look at all of the box tops and you kind of take an average, which you just have to take my word for it, that's basically this solid line right here. And then the 50 percentile is this black line, that median, the middle point. If you take and average all those, well, that's kind of basically right here, 36. And there's your volume, CTDI, and DLP. So this value, this 46, is actually a lot lower than the 60 up here, which is for the adults. But what I now am going to do is I'm going to take, there we go, and I'm going to I put this little tilde here, this approximate, because they're not actual national DRLs anymore. This is just data I acquired it was national data, but it's not been sanctioned as a national DRL. And so I apply that to our data here to just look at things. So once again, the 75th percentile of the data you saw on the previous slide, all of our values are below that. And then when I apply the 50th percentile, the achievable dose, potentially achievable dose for pediatrics, it is, for all intents and purposes, most of our data is below that, but there are some data points that every so often will just kind of pop up above it. So because everything is below the national DRL, or in this case, the pseudo national DRL, maybe we don't need to reduce the dose in our patients' population. So what we need to do when we investigate this is we need to ask ourselves, is there a reason, is the image quality appropriate for the task? For the appropriateness, for the clinical indication, is the image quality appropriate for what's being done? And from that, we can set alert levels. So whenever so often a little dot will pop up above this alert level outside of the trend of what we expected, then we as an optimization team know what to do or where to look to start our investigation. So when you, by setting the alert level here at at what we ended up doing is, if you set the alert level at the achievable dose, obviously we're going to get a few patients that'll will cause the alert level to go off. What we ended up doing is we set it at 115% of the value of this national achievable dose value. And so that was basically 40 milligray. And so if you look at our alert level is basically at this 40 milligray level. And basically over 2 years, that accounted for only 7 alerts. And so generally speaking, most of our data isn't causing an alert. But we wanted to set a value that when something comes up above that alert level, it's obviously much higher. It's 115% higher than that achievable dose level. And it's definitely higher, obviously, than our what the value we expect it to be. So here's an example. I drew a little circle around it. What caused this patient examination to cause a value to be above 40 milligray when the expected value was basically 35 milligray, this green line. So we looked at it as a dose optimization team, and we found out that this patient received a routine head CT and a CTA, so a combo of 2 scans. The routine head CT, so when we looked at it, it actually had the correct 35 milligray dose. So what caused the alert to be triggered? Well, it turns out that Radiometrics, whenever there's a combo, will take the two CTDIs and combine them. So the CTDI evolved for the routine and the CTA got added together. And it wasn't actually a perfect add, and so something was kind of weird with it, because the CTA is actually a little higher than only 10 milligray. But it caused the value to go from 35 up to basically 43. And so this was just a false alarm, 40.3, excuse me. So this was a false alarm. And so we still looked at it because it surpassed our alert value. And so what we needed to do is set the alert value, the threshold, and then as an optimization team, just constantly look at that. In most of our cases, in most of the cases that occur at our hospital, most of them are actually false alarms based on something that went wrong with the way Radiometrics combined the data. Now, I'm not trying to be negative towards Radiometrics. All dose monitoring software is going to have quirks, and not all of them are going to be perfect. And just every so often, one exam will maybe combine things in a weird way. But having that level, that alert level set, gives you as an optimization team a way to look at your data and know where to investigate. So now I'm going to expand this. I showed you, up to this point, I was showing you this data. 2018 data. I was showing you this data on this side over. So I was kind of showing you our good data. But what happens if I expand it and I go back further in time? And now you see all the way back to 2015, we actually had some pretty high values. Our average greater than 13-year-old and our average 6 to 12-year-old protocols were above what it would, quote unquote, call a pediatric DRL. And so when this occurs, when you actually draw that line, the DRL line, and then you start looking at your protocols above and protocols below, we realized we didn't feel comfortable with that. We looked at the image quality and we realized there's good image quality. Obviously, everyone's happy with that. But could we do as well below this line? So what we did is we decided to make several interventions. We ultimately ended up doing 6 interventions. Every time, what we did is we reduced the dose by 5%. So that's why you see this step, and then a step, and then a step, and then a step, and then a step, and a step. We just kept stepping it down. And every time we would reduce it by 5%, we would give it several months, and then we would collect data, and we would ask ourselves, so if we collect data for a month or two, and then we ask ourselves, we look at the image quality, And we asked the radiologists, how are they comfortable? Did a quick survey. Everyone was happy, everything's good. We determined the image quality is fine, looking at phantoms and doing the physics test. We would dial it down by 5% again, and again, and again. And eventually we got to the point where we dialed it down. You actually see there's only 5 lines here, is because we actually did 6 interventions, but we realized that 6th one was a little too far. And so we dialed it back really quick. And so that is how we found our sweet spot. We're happy with the dose, and we're happy with the image quality, and the ultimate reduction is we got about 35% total patient population dose reduction, and the net effect is our new values for the greater than 13-year-olds and our 6 to 12-year-olds, they're definitely below the DRL, and they're also now below the achievable dose. And everything else reduced also as well. So at every step, we reduced the dose, which is a good thing, but at every step, we were always investigating image quality, making sure that the radiologist got the right image quality to be able to do the right thing, and so they could do their diagnosis. Obviously, some key points here. As pediatrics, you need more than one alert level. So when you get your national DRLs back, that's wonderful. But a national DRL, I'll just flip back one screen. A national DRL right here may make it made a difference on these 2 protocols. But as you can see, even our little guys, our protocols for the littlest guys decreased. So we didn't just change what we saw in these ones, which were over. We chose to change the entire protocol, which was for clinical routine heads. And so even the little guys got a image quality and dose reduction. But if you set one alert level, it's hard because it'll only ever trigger for your adults or your large kids. It would never, ever, ever trigger for these little guys, these less than 6 months. But yet, look at this. There's this weird little clumping of data right here. Sometime kind of in the early to mid 2018, our things were going crazy right here. And what ended up happening is we were having some issues with those protocols, some software reloading and loading, some other issues that only affected this protocol. And so if you have an alert level that's set all the way up here, you will never see this problem. But if you have multiple alert levels, if you have multiple protocols, then you can even catch these weird subtle issues. And once you have your new tech software, your Bear or your Radiometrics, setting multiple alert levels is really easy. And then you'll just get an email every so often when something goes above that alert level. All right, and that's kind of what I said basically. You don't want to set the alert level so high that nothing ever triggers it. But if you set it too low and it triggers every day, well, first of all, you'll just, like I said, up to this point in our experience, most of them are false alarms. So if it's triggering every day and the preponderance of them are false alarms, at some point, human nature is just to start ignoring them. And that's not appropriate. And so you got to find the right place. You have to look at your data. You need to go in, do an average of your data. Especially, it'll be helpful once you got Radiometrics. If you don't have that, you can still do a quick survey of your data, and then from PACS or from your CT scanner, and from that you can then select your alert levels. All right, second example, maybe something a little closer to your home. In Japan, back in 2016, they had several hospitals that were doing routine head exams. This is for adults, non-contrast adult brain imaging. And they just took the data and they wanted to apply it compare it to their national DRLs. And these values, milligram per centimeter, this is the dose length product. So not volume CTDI, but these are DLPs. And here you can see for several protocols that used a helical acquisition, the values were much higher, statistically significantly higher than the national DRL compared to their old the conventional axial imaging that they did over here. So what did they do? As an example of what you can do also, they went immediately to their phantoms. This is a cat phantom, and they imaged it. And this is the low contrast module. So you have all these various different contrast level, these little circles, the diameters change at different locations in the phantom. And as they imaged it at different dose values, and they compared the conventional to what they proposed as a dose reduction. And what they found was and here you can see where they placed their little green ROIs. What they found was the dose-reduced images did not reduce object conspicuity. So they felt comfortable by doing this quick study, well, not quick, but doing this thorough study in the phantom, that if they made the same change in the patient population, that there wouldn't be an adverse effect, and that the image quality would still be okay at a dose-reduced level. So here you can see they acquired data for some time before the intervention. They made a change to the protocol. And then after that, they looked at the same patients. And they had, I'm not going to go into the details. They asked a couple of radiologists to rate some images, and they had a variety of different questions and different. But the point here, all I'm trying to make is, even though they looked at 4 different metrics, you can see that the overall magnitude of each of these colors stayed the same before and after the intervention. In other words, the image quality before the change and the image quality after the change stayed the same. And this is actually a great example of subjective quality scores. As I mentioned at the end of the last hour, there's really 3 ways to do this. There's the reader observer, or the subjective quality scoring. There's the mathematical reader observer, which, if you can, go for it. And then there's at the minimum, which is none of this, what you're seeing here. It is at least the radiologist sitting at the CT scanner, making sure when the scan happens, the image looks good, or they're in the reading room, just paying attention to these as they come across. In this case, if you read the paper, the Japanese paper, they actually had their radiologist champion, who was in charge of making this change. When they went live, that individual actually stood in the CT room. When the patient got scanned, the radiologist, actually looked at the images on the console just to make sure that they looked okay. He or she didn't do a reading, didn't do an actual diagnosis, but just made sure the quality was okay. All right. So in conclusion, so the I talked about and suggested doing a survey. So as you get the technology and the ability, the radiometrics and all that installed in Thailand, the next real big step after you've established your DRLs is to understand how you're using, obviously CT, but all of your other imaging modalities. We talked about various different dose reduction strategies. We talked about the appropriateness, establishing appropriateness criteria. We talked about how you can set different dose levels based on clinical indication. And then as a pediatric center, I recommend setting up protocols based on patient age. That said, for adult imaging, you probably only need maybe 1 protocol. Maybe if for whatever reason you feel like you have, when you survey your patient population, maybe there is more of the logarithm is maybe a little bit more steep for some of your adults. And so then you maybe have 2. But for the most part, I would say you need 1 protocol for the adult population. And then if you're imaging in the pediatric world, for the little kids, for 0 to 6 months, 6 months to 2 years, you definitely need 1 or 2, maybe 3 protocols at the very early years of the patient life. And the reason for that is because the younger kids, you can image their heads with 100 kV or lower. And that's a good thing because it gives you better contrast between gray and white, especially because the brain, for the kids' brains, tend to be a little bit more water-based. And so they do not have an inherently a lot of natural contrast. And so you really need to use lower kV to really make the two tissues, the parenchyma, separate. And so you can see them, the gray and the white, etc. Whereas after they matured, their brains aren't as water based. The parenchyma is not as water based. After 2 years old, the skull is, for all intents and purposes, more ossified and almost as ossified as an adult. Then in that case, you do need a more penetrating radiation using 120 kV, roughly right around there. And so that's why it's helpful to set up multiple protocols based on patient demographics. Obviously, it's important, if we can, to image as fast as possible using volumetric imaging or high pitch, the high bandwidth, the largest, not bandwidth, excuse me, scan width for pitch for helical acquisitions. And then, of course, we want to minimize radiation doses where impossible to the more sensitive aspects of the head, in the head, which would be the eye lens. So using organ dose modulation. If you have that as an option on your CT scanners, I recommend just turning it on. It's been my personal experience that just simply turning it on really does not affect image quality. If for whatever reasons you're CT scanning to look at the eye, then maybe you wouldn't. But even then, you're most of the time looking for objects or trauma. So you'd still be able to make a good diagnosis. We've never had any issues using organ dose modulation to reduce the dose to the eye. It's great because it does reduce the dose roughly by about 30% to the eye lens. All right, we reviewed DRL implementation strategies. I gave you 2 examples on how we looked at our values here in the US, and then how the Japanese, at least in that one study, looked at theirs. And then the way they approached it, we did ours at a stepwise process, just a little bit here, a little bit there. And at every step, we reviewed the results with radiologists. In the Japanese, they used a phantom to establish the initial change, and then they made an intervention and made a change, and then they were okay. So they only made one change, and they just went all in on that one change. Either way is perfectly fine. But in both cases, just worth pointing out, in both cases, there was always a clinical assessment, and I think that's really important. That's part of that whole optimization team. You need to have a radiologist there with you, so that they are the ones that have the eyes for what they need to see in the clinic. And we, the medical physicists, the technologists, even the IT PACS people, we're here to help them do their job. And so everything we've talked about, image quality optimization, dose optimization, all of that doesn't mean a thing if the radiologist looks at the image and they cannot they don't have diagnostic confidence. So that's the end of my second talk, and I turn the time back to you, Tanya.
Thank you so much, Sam. I do agree. Yeah. So radiologists, and I think like also technologists, are the gatekeeper in terms of appropriateness criteria to suggest clinician what they should order. Because couple times for me, I got a phone call from technologist and asked, yeah, doctor, I think the doctor, the ordering physician orders something, but I think it's inappropriate. What do you think? Can you confirm it? Is it correct or not? Should they do MRI instead of CT? So I think that helps us a lot. Yeah.
And I completely agree. And technologists, they don't get paid enough, right? They're doing so much work. They're working with the patients, they're working on the machines, and of course they're taking all the phone calls from angry doctors.
Yeah.
And so we love our technologists. Technologists are the best. They really do make I mean, obviously we talk about setting the right parameters, right, to get the best image quality and the lowest dose. But if the technologist doesn't do it right, then it doesn't matter. And so our technologists are wonderful because day in and day out, the good quality scans that our radiologists they get to do their study is because we have technologists, excuse me, that love their job and they are there to help the patient. So yeah, I love our technologists Yeah,
Yeah,
they sometimes they're the people we kind of talk about radiologists and we talk about physicists, but our technologies are right in the middle, and they're the most important part to get it all evenly flowing.
yeah, I do agree. I cannot be a good radiologist without good technologies and good physicists to help me in that part. So I have a question, Sam, about the organ dose modulating technique that you mentioned. How does it work? I mean, because we know that for the dose modulating technique, it uses like the thickness of the patient. But for the organ dose, how it work? Because some organ is in the anterior portion, like a lens. Some of them like a thyroid, or maybe like a in the body is like a inside. It's not in the superficial. So how does
Yeah,
it work? I mean, you just push one button and okay, it's work.
yep,
Mhm.
that's it. It's one button. It really quite literally is that simple.
Yeah, but I mean, like, what
Organ,
is the rationale behind that? Things like the deep learning stuff that they know this is the organ that needs to reduce the dose, or
it's getting there, but not currently. So right now, if you have organ dose modulation set up, you place the patient on the scanner. You're going to do the planar radiograph, or the scout, or the tomograph, or they all have their names. We'll just call it scout for now. And when they do that, then you have the scout image on, and you'll set your scan field of view. And there will be a second box that you would just put it over the eyes. And then the system knows as it's going right here, tube current modulation might be on, and it's scanning, it's scanning. But when it gets to that point where it hits where you are saying that organ dose modulate, then as it scans through that area, when the CT scanner spins over anteriorly, it will immediately reduce the output. And that's all it does. It just says, okay, from here it's low, 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 low. And then at this point, it picks back up and it goes back to normal. And it does that through the area which you indicate. And then at the point, I mean, you could be doing like a head and a face. And so then it would just go back to normal. So organ dose modulation is right now very simple. As you can see here on this, on my slide, it will only reduce the modulation, the the MA over a very specific arc. So for example, you see here these eyes are nice, well positioned inside this arc. What would happen if that head was too low? Well, then the eyes would be over here. And so, yeah, the organ dose modulation wouldn't do any good. And so that goes back to the idea of getting the patient nice and centered in the field of view. Now, what happens if the patient's laying with their head sideways? Now you got one eye over here and one eye inside it. Once again, organ dose modulation, especially for the face and the head, so the eye and the thyroid, it only works for a very specific angle. And when you're down here in the body, uh, it does it just for a larger angle. And so once again, if the patient is too low, then the breast tissue might actually be outside of that field of view. Or, if the breast is laying pendant, so it's maybe not exactly centered, then part of that breast might be outside of the field of view. It's not perfect. You did bring up the point about deep learning, and the systems are getting smarter. So when you do the scout image, the system goes, "Oh, hey, there's the eyes," and it will automatically set your organ dose modulation. That is the goal, but
okay.
currently it doesn't do that.
So right now it's like a box that like a technologist needs to put some box and label. Okay, this is the area that you need to do some modulating technique.
Yep. Yep, they get to specify that. So you could technically specify the whole field of view, and so it would do organ dose modulation not just for the lens of the eye, but it for the whole
For
the
my
whole brain.
eyebrow.
Yeah,
Why not?
gotta save your eyebrows.
Yeah.
Yeah.
But that this go ahead.
Oh, I was going to say, someone in the chat asked the question about could you
Yeah.
use this for pregnancy or for
Yes, this is
imaging?
gonna lead to the second questions for the pregnant woman or has a fetus. Yeah, that need a
Yeah.
CT abdomen. Mhm.
And so the answer is yeah, you can turn this on as it sweeps over anteriorly. The answer is yes, you are going to reduce the MA to that point. Obviously, the question is, where is the baby? you know, if it's a very second or third or late trimester, late uh, yeah, it's a late trimester birth or pregnancy, then the baby may not fully fit within this field of view. There was a paper that looked at this, and they asked the question, can you use this and would it reduce the dose to the fetus? And the answer is they said yes. And so in their case, they used this option. The one caveat I would say to that is if you are using, and I'm not trying to be negative about this, but if you're using a Siemens CT scanner, Siemens will reduce the MA on the anterior arc, and then it will increase the MA on the back side of it. So if you are a pregnant woman and the baby, and if unfortunately they're maybe not completely centered because they got a big belly, if part of the fetus is outside of that arc, it's going to get an increase of radiation. And so you have to be very careful using that one. Every other vendor out there, Canon, GE, they don't increase it on the posterior side. So in my personal opinion, that's fine. All it's doing is reducing the potential dose. And so, yeah, go for it.
I see. I see. Yeah. And my second question is about the dose alert level. So you said that we should set a level to alert. This is like a real-time alert, or is it retrospectively alert?
Yeah. And so you can look at that as two things. I actually didn't go into detail of this. I thought about this. Is there are prospective alerts and retrospective. So all CT scanners have the ability to have an alert built into it. And so you put the patient on the table and you punch in all your parameters. And when you click confirm, the scanner will calculate and say, oh, you know what? This MA and this KV, it's actually above what we expect. And so there's an alert level built into the CT scanner. And so the system will set up what's called a dose notification window. And it'll say, hey, by the way, this exam, this scan you're about to do is going to be higher than normal. Do you want to go forward? And then you would say yes or no. I mean, if you go, oh, I did something wrong, you can back up and go, oh, I changed my KV. I accidentally put 120 and it was supposed to be 100. Whatever happened.
Mm-hmm.
So that happens prospectively. Now, in our radiometric system, we have an alert level, and then we have a really big alert level in case something crazy happened. If for whatever reason the patient got scanned 2, 3, 4 times, I don't know, something crazy happened. In those cases, the system, Radiometrics, will immediately email me and a couple other people and say, hey, by the way, this dose was like 300% higher than it normally should be. But for all other purposes, let me go here. For all other purposes, these little dots out here that they're high, and I don't know why they're high, but they're high. So they're above right here. They're above this threshold. These values I only look at quarterly. And so the system collects them all, and then I plot my plots like this, you see here. And once a quarter, I meet with our dose optimization team and we review them. This is a retrospective approach, and it's a matter of going, okay, what went wrong? Let's try to fix it. But like I said, if there's ever something that's really high, then the system lets me know. And then even beyond that, the CT scanner itself and our wonderful technologists will have the opportunity to make an intervention or a change if something happens in the moment.
So does it mean you recommend at least having to alert level? The one is like a really high or like a dangerous level that need to do like immediately alert, like a real time. And the second level, we can review it retrospectively, quarterly or something.
So the answer is yes. And when it comes to it, the ones that are really high, you can set an alert level in the radiometrics, but let's be honest here. You already know about it because we have alert levels at the CT scanner. And the CT, you are not going to get that high unless you had to make a decision. And what happens when the patient gets on, you scan them, and something went wrong with the contrast. There's an extravasation or the contrast. We had this happen when the contrast squirted out of the contrast injector instead of into the patient.
Mm-hmm.
We scanned the patient, so contrast didn't go right. So they The technologist called the radiologist up and said, "This is what happened. Do you want me to scan again?" And the radiologist said, "I need these scans for whatever reason." So they reload it up, get the contrast back, and they go to scan again, and something else goes wrong. I mean, this is just the worst case scenario you could ever hope for. And so now you have to call the radio and say, "It happened again. We need to do a third scan." So what I'm trying to say is, when something happens out of the ordinary, at least at our hospital, and I don't know how you guys do it in Thailand, but in our hospital, the radiologist has to sign off on it. And if
Yes.
the radiologist says, "Yes, do it again," then we already know that. And what'll happen, at least for us in our hospital, is the technologist will say, "Hey, this happened," and and that's when people like me go, "Okay, I'll go look at it." Yes, then that study will be sent to Radometrics, and Radometrics will have that really upper level alert that'll go, "Hey, this is 300% higher than it should be," and I would get that email. But I'll be honest, by the time I got that email, I've actually already been called, and I already know what's going on. So the answer is yes, you could do it. And for a very busy hospital, or a hospital like you guys that maybe you share a radiologist, share a radiologist, share a physicist, then maybe it is good to have that really upper level, because then they will get emailed email notifications immediately, and even maybe a key radiologist like a chief or a optimization radiologist, they'll get that email, and so they might not even be on service that day, but then they'll go, "Oh, something happened," and so they can jump in. So you can do it, but let's be honest, a lot of the time the CT scanner itself will catch a lot of those mistakes. Well, not mistakes, but issues, and it'll let you know about it.
Okay, okay, that makes sense. Yeah. And my last question is about those reduction that you mentioned earlier. That is like a stepwise. Like, okay, you know this level, and now you try to reduce those a little bit and observe for the couple months, and then like a next step is reduce furthermore. So my question is, since we do for the brain, let's say for the CT head, we do fixed MA, helical modes, and we also do KVs 100 for less than 2 years old and 120 for more than 2 years old. What can you reduce? Fix, so you just like adjust the MA things, right? A
Yeah.
little bit at a
So,
time.
yep, that's a great point. And so it's exactly when you look at this, the KV is basically set for image quality for the contrast. So good gray white differentiation and penetration. So just like you said, basically under 2 you're 100 kV, over 2 you're 120 kV. Rough, it's rule of thumb. But to go from this step right here, this CTDI value here, down to this one and to this one, because we used fixed MA, all we had to do is just turn our MA knob down. That's
Mm-hmm.
simple. If you're using tube current modulation, then what you do is you have the noise index or the standard deviation value or the effective MA. Each vendor, each manufacturer has their own value. And what that number tells the system to do is how much noise to allow in the system. And so for a GE scanner, for example, noise index, if you're using tube current modulation, you turn the noise index up, which allows the system to let in more noise. In other words, it uses less MA. So in this
Mm-hmm.
case, I didn't change the MA knob. I can't turn the MA knob high or no. I can't do that. But I can say, I'm okay with a little more noise, that noise index value. And then the system will go from this step down to this step.
Mm-hmm.
Now, the only caveat to when you're using tube current modulation and you're trying to go from one step to the next, you set a minimum and a maximum acceptable MA on every protocol. And so when you change your noise index, it's going to go, it's going to pick an MA somewhere in between the minimum and the maximum. If you set your noise index, say, oh, I want a lot of noise, and you turn that real high. Well, the problem is the system is going to lower the MA, but it's going to hit this limit and it will not go any lower. And so you can keep turning that noise index knob all you want, but it hit that minimum MA limit and it will not go any lower. And therefore, you might go one step, two step, and then no matter what you change, you're not seeing any changes. I mean, no matter what noise index value you set, the noise index, the actual output would not change. And so tube current modulation, you have to change the noise index value, whatever it's called on each vendor, and you have to change your minimum maximum A. In this case, you need to lower your minimum so it allows less radiation. And so you can see it's a little bit more complicated with tube current modulation, which is fine, but fixed MA is really easy. It's just one number to turn.
I see. Yeah, I think like for me, we use the fixed MA things and 100 for less than 2 years old and 120 for more than 2 years old. And every patient who less than 2 years old, we normally do 3D reformatted images
Mhm.
looking for any skull fractures. That is like
Yeah.
one part to overcome the the detail on the bone that we cannot see it very well in the
Yeah.
100 kV. I think
Yeah.
that's what we do here.
Yeah. And that's great because that's, going back to our last talk, there's obviously all the other features we talk about, but there's, we can do the reconstruction kernel, we can get to the dose, all that. But a lot of the post processing techniques nowadays are just phenomenal, being able to do, 3D reformats and whatnot. And so, yeah, I mean, it's when it comes to optimization, that's why I say you need a team because there are so many. Going back to that, um, oh, there we go. Going back to this chart, if I can find it, optimization really is a very complicated process. And when you really get down to it, what we have historically said, when we say optimization, historically, most people just think dose. And that
Yes.
really is only, 6 or 7 different parameters to change. But to actually get true optimization, you need to do top to bottom optimization. And so it taught it, 3D reformats, image quality stuff, the right amount of dose, the scan field of view. Do we look at organ dose modulation? Are we doing the right appropriateness, set the right appropriateness criteria, clinical indication? I mean, there's just all of these things we have to take into account. And it's really good to have a team look at that so no one step is missed instead of just having the technologist do it or the, radiologist or physicist do it alone.
Yes, yes. So I think we don't have any questions from the audience right now and
Okay.
from the Facebook Live. But so let me ask one more question. So I know that we talk a lot about the CT head, but for the neuro study, we also have the soft tissue neck and also total spine. Can
Yeah.
you comment on that part a little bit?
Yes, and now that I think about it, I probably up to this everything is the same for the the brain. I focused a lot on the brain because we do a lot more brain than face. But when you're doing soft tissue face, you're looking at sinuses, and then you got your, inner ear. Those are
Yeah,
probably the next. Inner ears. Obviously, you need good spatial resolution, so you need good field of view, so that you can really see the tiny detail of the bone on the inner ear. Orbits, soft tissue for the face. You need to have the right noise content, but that's kind of the same as the brain. You just optimize the right MA. Obviously, there's still bone in the face, but not as much as we don't have the cranium. And obviously, if you're doing sinuses, it's mostly air filled. It's an air filled cavity that could potentially be filled with infection. So, water or fluid based. And so it doesn't actually usually require as much radiation. Typically, when we're doing face, just because when you look at the profile of the face, your face profile changes a lot more than your skull. And so using tube current modulation is great. But if you can, doing a single spin across your face, if you have the 160 millimeter scanner, that's appropriate too. Probably the most tricky, now that I think about it, probably should have included a slide on it, is the neck. And that's because if we're doing C spine imaging, well, C7, it's actually down here. And so there's a lot of shoulder involvement when you're trying to image C6, C7. And so typically we're going to start about T1, T2, and we're going to image up through, C1. Most scanners are okay, but the recommendation, the recommendation I would have is if you're having a hard time getting good bone conspicuity, good edge definition when you're looking at like a sagittal C spine, is don't image down, start imaging top and bottom up. And the reason behind that is I mentioned that when your system is trying to ramp up radiation, you obviously need a lot of radiation to get through your shoulders compared to your neck and even like the jaw to get up to C1, C2. And so when you start imaging right here, you don't need a lot of radiation. So you'll start with a moderate amount, but then as you start scanning down, once you get into the neck, your actual, if you look at the dose profile, it's going to go up and then it's actually going to go down. There's not a lot of tissue here. And then when it goes from this neck to these shoulders, it needs to go up really quick. And to get it to go up really quick, you either have to have a very low pitch so the system can modulate quickly,
Uh-huh.
or you start at the bottom and you go up. And so it starts at the high dose. And a system could reduce the dose pretty quick. And so you can go normal dose, high dose down to low dose, and the system is perfectly fine doing that. So we had a lot of problems with our C spines for a long time. And the biggest fix, we tried everything. We tried KVs, we tried higher MAs, we tried everything. The biggest change was when we just started imaging from the bottom up. And that's
Oh,
just because the system can reduce the dose from the shoulder to the neck really quick versus flipping it around. And so our biggest issue, our biggest complaint from our radiologist was really C6 or C5 through C7. It's just when you looked at it, you just the borders of the vertebrae were just were kind of almost translucent and at times almost gone just because the noise content. And so anyway, that's my biggest suggestion.
this is a good point because I don't know about this thing before. I just okay, why image quality is so poor in the lower C5 or something, but I don't know that because of the those stuff that we need to scan from
I'll
down up.
yeah,
Yeah.
I know next week is the body. So
Uh-huh.
I'll actually include a couple of slides and I'll show you what it means to go from the bottom up versus the top down.
Okay.
And I'll show a couple examples of a sagittal C spine. And
Yeah.
hopefully you'll have a
So
good
which
way. We
means
can
this
talk
can
about it a little more.
yeah. So which means this can help with the CT cervical spine and also CT soft tissue neck.
Definitely. Yes. Yep. Yep.
Wow, thank you so much, Sam,
No problem.
for the excellent talk and give us more detail and very practical point to work
Yeah. There's
to help with the
nothing
organization in
it,
the protocol.
yeah, there's nothing funner than talking physics at midnight. Or at least midnight at my time.
Yeah, yeah. But I learned, yeah, I learned a lot from you. Thank you so much.